Hi, everyone. Thank you so much for coming today. Happy recess. Really thrilled to see such a packed room and such interest in Medicare Advantage. So I'm Lisa Hunter. I am the Director of Government Affairs and Alliance Engagement at Better Medicare Alliance, BMA. Again, we are so delighted to have you guys here. We're also really thrilled to have such an esteemed panel that will give you sort of a window into Medicare Advantage and practice. But first, we're going to start with a couple of housekeeping items. And, the real goal of today's briefing is to make sure that you all are equipped with the basics of Medicare Advantage. Some of you guys are very familiar with Medicare Advantage. So this is a good opportunity to just brush up on the content and also hear from our experts around what's happening in Medicare Advantage. It's also great if you don't know anything about Medicare Advantage, so we certainly are excited to see you. We're going to throw a lot of information at you. You're going to have a lot to digest, and the good news is that we have a folder which has a lot of resources, and the good news from that is my business card is there. So if you ever have any questions, you know exactly how to reach me. I'd love to engage with you all. So please don't hesitate to reach out if you have any data points that you're looking for or any sort of information on Medicare Advantage that we can be helpful with. We're going to start. I'm going to kick it over to our President and CEO, former Congresswoman Allyson Schwartz, in a moment. But before we do that, I want to get through a couple of housekeeping items. So you have the folder of materials. What's inside is pretty self-explanatory. You have the slides from today's presentation. There are some fact sheets in there and some resources and data. But if I may, I just want to draw your attention to a couple of resources that we provide, as well as give you a couple of concrete asks for you to take back to your team and to your boss. The first item that I want to flag for you is if you ever want to know how many Medicare Advantage enrollees are in your state or in your district, there is a place for that on our website, bettermedicarealliance.org/map. You can go to it on your phone. I use it all the time. It gives you a breakdown of not just folks who are Medicare eligible, but also folks who are enrolled in Medicare Advantage plans in your district and your state. Similarly, if you'd like information from us on policy updates or if there's a rule that drops, we send out pretty regularly, a quick and simple policy alert or a digest of some of these policies that are coming out. So if you want to be added to our list, you can go to our website for that as well. And there is a sheet inside your folder that has a map on it with the link for policy alerts. So it's bettermedicarealliance.gov/policy-alerts. And then we also have a couple of asks for you. So another thing that's in your folder is a Dear Colleague that we're hoping your bosses will consider signing on to a letter from Congress to CMS, encouraging CMS, the agency that oversees the Medicare Advantage program and Medicare writ large, encouraging CMS to expand the number of languages that it uses when it communicates through educational materials and through its website for Medicare beneficiaries. So right now everything is in English and Spanish, which is great, but we're really encouraging them to take another step forward in translating some of these materials for beneficiaries into additional languages. Finally, our next ask is on the health insurance tax, and we're hoping that your bosses will consider signing on to in the House, it's H.R. 1398, and in the Senate, it is S-172. So these are being led by, in the House, Ami Bera, and in the Senate, Cory Gardner. And these are bills that will delay the imposition of a health insurance tax on commercially covered lives, including Medicare Advantage lives. So this is a really great Congress has done this in the past. I'm sure you'll hear about it today. But for members who are looking for ways to keep premiums down and avoid a spike in premiums, this is a very tangible bill that does just that and delivers on that for constituents. So again, it is 1398 in the House, and in the Senate it is S-172. So I'm going to turn it over to BMA's leader, President CEO, Congresswoman Allyson Schwartz. She hails from Pennsylvania, so many of you may recognize her. She served in the House of Representatives from 2005 to 2015. While in Congress, she served on the Ways and Means Committee and on the Budget Committee. and has played a leading role in a lot of reforms happening during that time. So she was instrumental in authoring the provision to ban excluding coverage for individuals with pre-existing conditions under the ACA. She's also a strong advocate for access to primary care, value-based payments, innovation, care coordination, and cost effectiveness. Prior to serving in Congress, she was a member of the Pennsylvania State Senate, where she led the design of Pennsylvania's CHIP program, which was a model for the federal CHIP program. And she currently serves on a number of executive boards, including the Executive Advisory Board of the Leonard Davis Institute of Health Economics of the University of Pennsylvania and the Advisory Board at the Wharton School Penn Wharton Budget Model, and is a member of the National Hospice and Palliative Care Advisory Board. That's quite a mouthful. Anyways, without further delay, here is Congresswoman Allyson Schwartz.
Thank you, and good afternoon, everyone. It's wonderful to see a full room. I think doing these briefings on recess days or recess weeks is a good idea. You have a little bit of time to actually get into a little bit of a deep dive on a subject. So we're really just delighted that you're here. And I have to say, we are also delighted in the really strong bipartisan support for Medicare Advantage. This year, our rate notice letter, which was circulated, had 302 members of the House, including 65 freshmen, sign on to the rate notice letter supporting Medicare Advantage and telling CMS that they did, which is great. And we had 66 senators. So that was really an impressive number. We were really delighted with it. Everything should work that way, right? It would be a little easier on you all if it did. But we really are very pleased about that kind of bipartisan support. But we also fully recognize that so many of you have either new or changed offices. Some of you are working with new members. Many of them are smart and wonderful. Not all of them know Medicare. And really understanding Medicare and understanding Medicare Advantage, we hope will give you a huge leg up in helping to advise your offices and your bosses about when to sign on to such letters, and of course, as we debate Medicare going forward or healthcare reforms going forward, we hope that you will think about Medicare Advantage and not only how it works, which you're going to hear about today, but about the innovations that are happening in healthcare today. And that's one of the reasons we have a panel with us today, so that you can hear from James Michel, who will come up next, to talk about Medicare Advantage and just how it works. And again, you will have this information. It'll be available to you, so you can take some notes, but it is available to you. But if you have questions about Medicare Advantage or how it works, really let us know. Be in touch with us. Go on our website. Ask us questions. We don't think any questions are stupid. We've all had to learn. I thought I knew a lot about healthcare, and still is something that seems new to learn all the time in Medicare Advantage. Better Medicare Alliance is an alliance of, we're only around about 4 years, actually, since I left Congress, putting together this organization. Started with about a dozen ally organizations. Really, we wanted to represent the variety of stakeholders, the diversity of stakeholders who care about healthcare and care about Medicare in particular. And we now have, as I say, 130 organizations, and they range from, well, the three I'll introduce in a minute. They're all represent our ally organizations, but we have health plans, we have health systems, provider organizations, we have national professional associations from the American Nurses Association and the Osteopathic Association to Telemedicine Association and the SNP Alliance and the National Association of Mental Illness. Someone is called, it's NAMI, it's the other one, got the letters in the wrong direction, but it is, and we also have community partners now, YMCA, Meals on Wheels, some of the organizations that really are already doing good work, working with Medicare Advantage plans, but also are really excited about the new flexibility that is enabled now under Medicare Advantage to be able to provide benefits. I've always been able to do this, but benefits that don't exist in fee-for-service. And that includes ones that have been around for a while: dental, vision, some hearing, wellness programs, care coordination. Those exist within Medicare Advantage in a way they don't in fee-for-service, but now are able to add meals and nutrition, transportation, and in-home care, as well as home modifications. Not for everyone, it's targeted for people with chronic conditions, but it really enables Medicare Advantage to do something that is not easy to do in fee-for-service, if not impossible, which is really to tailor benefits to the individual patient's needs, particularly those with chronic conditions. So this all matters because, in fact, there are 10,000 new seniors a day in this country. We are going to double the number of seniors in the next 20 years, and seniors will grow from about 12% of the population to 20% of the population. So it's going to affect every part of what we do in this country, from housing to transportation but nothing it touches as much as healthcare. And what it's going to mean to the healthcare system stepping up and understanding what the needs are of today's seniors and seniors tomorrow. So those baby boomers, I'm one of them, are really going to shake things up. We thought we did a long time ago. Millennials think they're shaking things up, but we're actually going to be a bit disruptive ourselves in actually expecting and really needing healthcare services that are tailored to us. And certainly a capitated system, you'll hear more about that today, is one that we think offers the opportunity to really be able to move dollars around in healthcare that really can be very patient-centered and meet people's needs. So that's what we're going to talk about. And our panelists, and I do want to just quickly introduce them now, or they're going to sit quietly for a while, but you get to ask some questions later. We have Jane Gilbert from, I want to make sure I say this correctly, just she'll correct me if I get it wrong, from Kentucky. She's the director of retiree healthcare at the Teachers Retirement System of the state of Kentucky. And she's been an incredible advocate for a particular part of Medicare Advantage, which is called, employer group waiver programs. These are employer-sponsored programs. She'll describe them to you, where a group of employees, usually who had their employers promise them health care benefits for a lifetime, meeting that commitment turns out not to be so easy, and Medicare Advantage makes it easier. And Jane has really been a leader and outspoken about how important this has been to teachers in Kentucky and how important it is across the country. So thank you, Jane, for joining us again this year. And we have Chet Speed next to her. He's Vice President of Public Policy at the American Medical Group Association. Those are all the large medical groups that you hear about sometimes, and he can tell you about some of them. I think, we just talked about Cleveland Clinic and Henry Ford's system, but really Geisinger in Pennsylvania is one. There are many, actually, as a matter of fact. And again, these are medical groups that have been leading the way in really capturing how you take care of a population of patients over time and the kind of innovations that they have been engaged in and excitement they have for working under Medicare Advantage, that financing of Medicare Advantage, and how it enables that kind of care for seniors. Used to be kind of got cut off when you're 65, and now it doesn't. Medicare Advantage allows that. And last, one of our newer ally organizations doing really very important work representing a provider group called Oak Street Health is Dr. Griffin Myers, and out of Chicago, but now opening health centers in a number of communities, or targeting minority communities with at high risk, high need beneficiaries, and really creating not only health care, but really community centers for their population of patients. So Dr. Myers, we appreciate your being a part of this and for your leading way, and they just opened 4 centers in Philadelphia. So looking for some transformation there as well. So let me just close by saying I'm going to I'll be back up to moderate the panel, the opportunity for questions. I don't know if we're doing little cards or not, but just raise your hand. Just raise your hand later. We'll be able to ask some questions. But now I want to turn it over to James Michel, who is Better Medicare Alliance's Director of Policy and Research. So he's a smart guy on the block, so we definitely give him the hard questions. No, he's telling me no. But I want to introduce James Michel, again, BMA's Director of Policy and Research, to really walk through this slide deck about really how Medicare Advantage works. Thank you so much for being here.
Thank you, Congresswoman, and good afternoon, everybody. Happy recess. Thanks for taking an hour out of your lunch to spend with us to talk about MA. So I'm going to try, again, my name is James Michael, Director of Policy and Research for Better Medicare Alliance. My plan is to walk through a lot of material in a short time frame. I timed myself on this a few times and did not succeed once within it. So I'm going to move quickly through some of these sections. So please, if you want to grab me kind of after the event with any questions, but I will also, again, just direct you to the resources on our website. We have a slew of policy papers, most of which have one-page fact sheets that are easily digestible on virtually every issue we're going to talk about today. So let's go ahead and dive right in. So we'll start first with what is Medicare Advantage. At its most basic level, Medicare Advantage is one of two primary ways through which Medicare beneficiaries can receive his or her Medicare benefits. The other option, of course, being original fee-for-service Medicare, which goes by traditional Medicare, original Medicare, fee-for-service Medicare. I'll try and stick to one term, but all of those terms apply to fee-for-service Medicare. The most fundamental difference between Medicare Advantage and fee-for-service is the fact that the government administers the benefit in fee-for-service Medicare, and by administers it means they process claims, pay providers, that type of thing. Whereas in Medicare Advantage, it's a health insurance organization such as Blue Cross Blue Shield or Aetna that administers the Medicare benefits on behalf of the beneficiary. Insurance companies that wish to offer Medicare benefits through Medicare Advantage follow pretty stringent rules. We follow those rules very closely. As an example, at the most base example, they must cover all of the Medicare covered benefits at a minimum. And as Congresswoman Schwartz alluded to a few moments ago, they may, and most times do, offer benefits above and beyond what original Medicare covers. Those are known as supplemental benefits. And in a few slides, we'll go into some more depth around what those look like. There are a bunch of other rules that plans have to follow, some of which we're going to cover throughout the course of today's presentation. But in short, Medicare Advantage is a very heavily regulated program. And it needs to be to ensure that patients receive access to care that is high quality and integrated, and that it's done in a cost-efficient way. Other key differences between Medicare Advantage and fee-for-service include in Medicare Advantage, plans have provider networks that they contract with, through which people must receive their care, whereas in fee-for-service Medicare, you can see any Medicare certified provider throughout the country. And there are costs and benefits to both models, but the value of networks can't really be understated. And then Medicare Advantage may and often does have different cost-sharing rules, so different rules in place for what patients pay either at the doctor or at the hospital. A lot of times those copays and cost sharing are lower than in traditional fee-for-service Medicare, but the most important distinction is that in Medicare Advantage, there is a true cap on out-of-pocket expenses that patients pay, and that cap, that limit doesn't exist in fee-for-service Medicare. So that's kind of a bread and butter. The key differences. This next slide here goes into a bit more detail about how Medicare Advantage fits into the broader picture of Medicare. We know that original Medicare is Part A and Part B. Part A is hospital-covered services or anything in a facility like a nursing home. Part B is your physician coverage, so when you go see your primary care doctor or go see a specialist, and those are two distinct but related insurance programs. They have different cost sharing. Part B has a monthly premium that beneficiaries pay, typically out of their Social Security. Part A has a deductible. So there are these kind of complex cost rules in Medicare Part A and B. And then, of course, we know Medicare Part D is the most recent of the parts of Medicare. That is the prescription drug benefit. Through which beneficiaries get their pharmacy medications. So Medicare Advantage is Part C, and rather than it being a distinct part of Medicare, it really is the other three parts wrapped in one. Most Medicare Advantage plans, so all Medicare Advantage plans cover all Part A and B services. The vast majority of plans also have Part D coverage included. So Medicare Advantage is kind of like a one-stop shop for getting your Medicare benefits. And so these different parts are often talked about as if they're separate and distinct, but we look at Part C as kind of an amalgamation of the other parts, which will be important when we talk about integration of care later in the presentation. So there are different types of MA plans on the market. The most common are just regular individual MA plans where seniors, enroll individually in a plan of their choice. But there are also specialized plan types. Congresswoman Schwartz alluded to these retiree plans offered by employers called Employer Group Waiver Plans, or EGWIPs, which I did not use that term before I went to BMA, and I use it all of the time now. EGWIPs are not insignificant, as you'll hear from Jane. They represent 20% of the Medicare Advantage program at large, so a pretty significant and growing portion of Medicare Advantage. There are also special needs plans, which are specialized types of plans focused at different populations. So they have special needs plans, or SNPs, for dual eligible beneficiaries. And those plans really work to integrate the Medicare and Medicaid benefits. You also have what are called institutional SNPs, which are specialized plans for those beneficiaries who reside in an institution such as a nursing facility. So that's kind of broadly what Medicare Advantage is, the types of plans out on the market. And so now let's talk a little bit about who is actually enrolling in these plans. So Medicare Advantage enrollment is strong. It sees roughly 8 to 12% growth year over year. This slide shows the growth in enrollment from 2015 and then projects out to 2027. It is the Congressional Budget Office that makes these projections. So you can see here that the CBO is projecting Medicare Advantage to continue its growth trajectory and to gradually become a larger and larger share of the Medicare program overall. But the most important metric that we look at are the ratio of beneficiaries every year who are opting into Medicare Advantage rather than defaulting into fee-for-service. And that number keeps growing. And if that number keeps growing, then the portion of Medicare that is represented by Medicare Advantage will also continue to grow. I think the most recent enrollment numbers from just this past year, I think roughly 50% of beneficiaries aging into Medicare opted for a Medicare Advantage plan over fee-for-service. So we're hopeful, because of the great work and success we've seen in Medicare Advantage, that those trends continue forward. And I do want to note the CBO projections to the right of the dotted line. CBO actual enrollment growth has exceeded CBO's projections regularly. So we would expect, I think, to see these numbers a little bit higher. So now that we know how many enrollees are in Medicare Advantage, what do they look like? So what do enrollee demographics in Medicare Advantage look like, particularly when we compare them to fee-for-service Medicare? Well, first and foremost, we don't see that many core demographic differences in terms of age. They are roughly the same age. I think the slide says, yeah, that's right. Around 71 years of age is the average in both programs. Same for the chronic condition profile of the populations. The patients in MA tend to have the same prevalence of chronic conditions, the same number of chronic conditions as fee-for-service. Beyond that, though, we do see some differences in the two populations. So this slide shows a little bit of a teaser of some analysis we're currently doing. So I'll caveat by saying these numbers are draft, and in the next few weeks, we are going to be pushing out an updated enrollment and demographics issue brief of Medicare Advantage. So with that caveat, what these numbers show are from 2016. This data was taken from the Medicare Current Beneficiary Survey, or MCBS, which CMS administers to Medicare beneficiaries both in fee-for-service and Medicare Advantage every year. The survey actually if you're a beneficiary selected for that survey, you take it for 3 years in a row, so they can also get some trend data from that as well. So just some key differences we started to see in our analysis in terms of gender. A higher proportion of Medicare Advantage enrollees are female compared to Medicare Advantage, or compared to fee-for-service Medicare, which I think makes sense and this is not, sexist, but women tend to be the shoppers of healthcare in the family, and so they're the ones making decisions about coverage, and so I think that is something we would expect to see. In terms of race, whites and Asians are slightly less likely to enroll in MA, whereas African Americans, Hispanics are more likely, particularly Hispanic beneficiaries are much more likely to enroll in Medicare Advantage compared to fee-for-service. In terms of income, we see that a greater share of the Medicare Advantage population has an income below 200% of the poverty level, which in 2016 was about $32,000 a year for a couple. In terms of education, we see a greater share of the Medicare Advantage population having less than a high school level of education, and a greater share of fee-for-service beneficiaries having completed college. So we do see some real demographic differences in these populations that are due to, a number of different reasons, but do, lead us to make some conclusions about the types of benefits and care offered through Medicare Advantage and the value that they can bring. In terms of where Medicare Advantage is available across the country, this map shows by county the availability of Medicare Advantage plans. The darker the shading, the more plan options there are. So you can see in almost 600 counties, there are at least 20 options for folks. You can see that there tend to be more MA plan options in certain regions of the country, such as the Northeast, around dense urban areas like Southern California, Miami, the big cities of New England. There do tend to be fewer MA options in rural areas of the country, although there are very few areas where there are no options at all. Alaska is a good example of a state that has no individual MA, but they do have an EGWP, actually. So that said, more than 99% of Medicare seniors have access to at least one MA plan option where they live. This next map shows the same availability, but for plans that offer a 0 monthly premium. So these are plans where the beneficiary pays no monthly premium for an MA plan with prescription drug coverage, which is called an MAPD plan. There are roughly just over 7.5 million of the 22 million people are enrolled in these plans in 2019. They're highly popular. In markets where they're offered, they're highly competitive. They tend to be a lot of zero premium options, so they are a solid, attractive, and valuable option for a lot of seniors today. And we'll talk a little bit more when we get into payment in a moment about how it's even possible for Medicare Advantage plans to offer plans at no premium at all. Okay. So I am going to slow it down for this, for payment, because it does get a little complicated. I won't get too technical with it, but in general, CMS pays Medicare Advantage plans a set amount per enrollee per year. It's known as a capitated rate or capitation. They're paid the same amount regardless of the services utilized, so that means that the Medicare Advantage plan is at risk for that spending. Whether they keep costs low or they see higher costs, it is the plan on the hook for that spending. So CMS establishes what that payment rate is by the following process. So first, CMS calculates a benchmark for every county in the United States. This benchmark is basically an average of what it costs fee-for-service Medicare to care for the average Medicare beneficiary. So it's a direct comparison to what original Medicare spends. Then what plans do is they submit a bid to the government, which is their estimate of what they think they will need to offer care to their enrollee population the following year. And that bid is then compared against the benchmark, and there are a couple of things that can happen. And we have an illustrative example here, which I I won't take credit for Avalier Health, which is a consulting firm, gave this to us a while ago. I use it in almost every presentation, so thank you, if anyone, Avalier. But in the example on the slide here, what happens when a plan's bid is above the benchmark, as on the left side of the graph, that green, when the bid is above the benchmark, that difference is paid by the beneficiary in the form of a premium. In the example on the right side of the slide, where the plan's bid is below the benchmark, then that difference between the bid and the benchmark is split between the Medicare Advantage plan and the government. So the portion that the plan keeps is known as a rebate, and it's not to be confused, as you've probably heard a lot recently with rebates in the Part D program. They are distinct and different. But these rebate dollars are really important because there are very strict rules that plans must follow for using that rebate money. At its basic kind of understanding, it must be used to benefit beneficiaries. And so it can be used to lower premiums. It can be used to lower cost sharing across the plan. And these are the dollars that are used to fund what we call supplemental benefits, which are those benefits above and beyond what is covered by original Medicare. So as you can see, there are really strong incentives in this payment structure to encourage plans to bid below the fee-for-service benchmark, because it means they get more resources to offer more things to beneficiaries that make their plans more attractive competitively. So, and this is a really oversimplified example. In reality, that payment rate gets adjusted for several different factors. For example, there's what's known as risk adjustment, where depending on the clinical profile of the patient, that payment goes up or down. And the purpose of risk adjustment is to ensure that the plan has enough resources available to care for a patient who's likely to cost more money than the average patient. And what this does is it removes any weird incentives for plans to avoid sicker enrollees. It kind of levels the playing field and makes it really about what the patient's care needs are rather than about the dollar. There are also a lot of other adjustments to it, and I'll just go ahead and plug, we have a white paper on payment that's about 30 pages, so it's a light read. You can put it next to your bed, helps me fall asleep. I didn't say that. So, there's also some adjustments made to that rebate amount. So if you're an average plan rated 3 stars on the Quality Star rating system, you keep half of that rebate, you give half of it back to CMS. If you are rated a 3.5 or 4-star plan, you get to keep a larger portion of that rebate. And if you are a 5-star plan, you get to keep, I think, 70% of those rebates. So there are quality incentives built in as well for plans to focus on quality improvement so that they have more dollars available to offer these benefits. Okay, so we get asked quite often, and you might too, actually, what does payment in Medicare Advantage look like relative to fee-for-service? Is the government essentially saving or losing money on Medicare Advantage relative to fee-for-service? And I just wanted to throw this graph up here. This table is from the recent report from the Medicare Payment Advisory Commission, or MedPAC. They just put out about a month ago, where they find that on average, plans are bidding well below the fee-for-service benchmark. So here we look at HMOs, health maintenance organizations, which are the most common and popular type of MA plan, are bidding at like about 89% of the fee-for-service benchmark, which is great. It means they have rebate dollars to offer extra benefits and keep premiums low and that sort of thing. But when you look at kind of how it all washes out in the end, what CMS has found is that payments are now at parity between the two programs. Before adjusting for coding, which I'm not going to get into today, but we also have a paper on that. So I recommend you go take a look. But essentially, the government is paying Medicare Advantage about the same as it pays for similar patients in fee-for-service, which is a great story because Medicare Advantage offers all these extra benefits. It's an integrated system of care, and plans are able to do it at the same or lower cost than what it costs the government in fee-for-service. So let's take a couple of minutes to talk about supplemental benefits. We've mentioned them a lot. Supplemental benefits are defined as items or services that are not covered by fee-for-service Medicare, but may be offered by MA plans. Now, in the law, supplemental benefits must meet 3 specific criteria. Those criteria are in the boxes on the slide. They must not be covered by fee-for-service Medicare. They must be primarily health-related, which is an important standard we'll talk about in a second. And the plan must incur some type of non-zero direct medical cost to provide the benefit. The most common types of supplemental benefits include coverage for coverage for hearing and hearing aids, vision services, and to Congresswoman's comments earlier, they include things like wellness programs, fitness benefits, nurse hotlines, social work lines, and that sort of thing. So these kinds of wraparound benefits that are of very high value to patients, but which Medicare just simply does not cover. So there were some really important policy changes happening around supplemental benefits in the last year. Last year, CMS changed its rules around the types of supplemental benefits that could be offered for this year in 2019. And they did that by relooking at their interpretation of that primarily health-related standard. And effectively what they did was they broadened their interpretation of that criteria to allow an expanded type of benefits in 2019. The slide here shows that the most prevalent new supplemental benefits we've seen this year. They include social worker lines, non-skilled in-home care aides, coming into the home to help with activities of daily living, house cleaning, meal prep, and things like that. Also support for caregivers, so respite for family members or friends who are caring for a loved one. Those were the most prevalent new kinds of benefits this year. The most prevalent preventive new benefits that were offered, things around remote access technologies, fitness benefits, and health education. And so that was what happened in 2019, but what we're really looking at is 2020 and beyond. So what happened last year was the passage of the Bipartisan Budget Act, the BBA, of 2018, which many of you and your bosses worked on. It included some provisions of the Chronic Care Act. And there was one provision in the Chronic Care Act that further expanded supplemental benefits by creating a brand new category of benefits for those who are chronically ill. And the government is going through the process now to define what chronically ill means, but it's basically having one of a list of defined chronic conditions. So in the way that the law made that expansion was by completely getting rid of that primarily health-related standard altogether. So what this did was open the door for plans to provide non-medical benefits like transportation, but not just medical transportation, transportation to and from the grocery store or to the pharmacy. Anything, any service or item that has a reasonable expectation to maintain or improve health, which is a very broad definition. You can figure plans are fitting a lot of different and innovative things into that definition. It includes things like home-delivered meals, food and produce prescriptions, home safety modifications like grab bars, like improved lighting, pest control. So you could envision an air purifier for somebody with chronic asthma as a benefit now. So these new benefits are kind of they're a new ball game for, I don't do sports analogies very well, but they basically open the door to a whole slew of new benefits. And plans are currently in the process of figuring out exactly what they'll be able to offer for next year in their plans, exactly what they think will provide the most value for their enrollees, and we are anxiously waiting, like everyone else is, to see how plans take this new flexibility and design their benefits for next year. So now we'll take a couple of minutes to talk about how quality is assessed and measured in Medicare Advantage. So as I referred to a little bit ago, there is a quality star rating system for Medicare Advantage plans. It's a 5-star system similar to the one for hospitals and nursing homes and home health care providers and that sort of thing. And star ratings measure a Medicare Advantage plan's quality on health management and outcomes across a range of different measures. This year, I believe there are 48 individual measures covering both Part C as well as Part D to which plans are held accountable. The ratings range from 1 to 5 stars, with 1 being the poorest quality and 5 being the best. And it's calculated based on how well plans perform on average across all of those measures. The current, I said this already, ratings are based on 48 individual measures, and they fall into those 9 domains that are listed on the slide here, including member experience, so things like patient satisfaction or number of beneficiary complaints, but also customer service. There are health outcomes measures in there as well. So plans are rated at the contract level, which is a little bit of a wonky term, but essentially a plan has a contract with the government and they can offer several plans under that contract, and the quality rating is applied at the contract level. Although, as Congresswoman Schwartz and I know from work that they're currently doing, they may propose a change in how they do that. We won't get into that. We also have a white paper on quality on our website, so please feel free to peruse that. So this is how the Quality Star rating system is currently used today. It's currently used in 3 different ways. The first, obviously, is beneficiary choice. So Quality Star ratings are marketed, they're included in the plan finder, so when beneficiaries enroll in MA, they know what the overall quality rating of their plan is. It's used in quality incentives, so we talked a little bit ago about how the higher a plan's quality rating, the more rebate dollars they get. There are a few other mechanisms like that in the way MA plans are paid that really financially incentivize a focus on quality improvement. And then, of course, it's used as a compliance tool for the government, so another method for how CMS oversees Medicare Advantage plans is through this. So one example is if you're a plan who's consistently rated below 3 stars, CMS will terminate your contract, or even before that, they'll freeze your enrollment. So they use it to really hold plans accountable to making sure that beneficiaries are receiving the right care at high quality. And then this is not really quality, but there are a bunch of other areas of how Medicare Advantage is overseen by the government. Those oversight areas include provider networks and network adequacy. So we talked a little bit ago about how Medicare Advantage plans have provider networks. Those networks must follow, they must meet specific standards, and the government monitors and oversees plans abiding by those standards. They do data and audits as a way of compliance. They review the bids that plans submit every year, and they approve or not those benefits, including cost sharing and that sort of thing. They oversee encounter data, which is basically similar to claims data. It's the data that's captured at the interaction between the provider and the patient. CMS is doing a lot of work around encounter data now to better understand what happens in Medicare Advantage. Appeals and grievances, and then they oversee marketing and communication to beneficiaries. And that concludes my part of the presentation. I think we'll turn it over to the panel now, but I do want to thank you guys again for sitting through that wonky, technical, and pretty fast presentation. Thank you.
Thank you, James. This is great. Well, I hope most of you stick around because this is is a background for what I think most of you really want to know, which is, so how does this really work in the real world? How does it matter to beneficiaries? How do providers react? How does it help make sure that people have access, Medicare beneficiaries have access to high quality, comprehensive benefits, and how are we doing it in a cost-effective way? So we have a panel, and I'm going to ask each of them to speak to their perspective on why Medicare Advantage matters to the work they do and how it enables the work that they do. So, Dr. Myers, do you want to, we'll start maybe at that end of the table.
Yeah, of course.
That'd be great.
So my name's Griffin Myers. I'm an emergency physician by training. Started an organization about 6.5 years ago called Oak Street Health. We focus on providing high-quality primary care and social determinant support to folks living in low-income, medically underserved communities around the country. So we currently operate about 40 centers. There are a few more under construction, but they're in places like South and West Side of Chicago, Detroit, Indy, Philly, Cleveland, Flint, Michigan, Providence, Rhode Island, Memphis, Tennessee, a few places in North Carolina. So we have a pretty unique model in that because we focus exclusively on that population, it means we can build a care model that specifically targets the 60,000 people that we get to take care of and supports them with all the things that they need. That's things like transportation to and from the center. We have community centers in every one of our centers. We see patients on average 9 times a year when the average Medicare beneficiary has 3 primary care visits in a year. Our visit length's like 30 minutes instead of the average is about 17 minutes. But it's really all made possible through this payment mechanism, which really operates through Medicare Advantage. So the way that we work is we are not a traditional fee-for-service practice. We don't get paid to see patients or do visits. We get paid essentially that premium from our partnership with our health plans. So we partner with 13 different Medicare Advantage plans around the country. Our patients have a lot of choice. There are tons of plans in all the places that we work. The overwhelming majority of our patients have 0 premium plans. And in fact, over half our patients are dually eligible, meaning they're old enough for Medicare but also poor enough for Medicaid. So the average patient, for all the stuff that we do, they pay us $0.00. But it means that we're able to not worry about doing fast visits a lot of times. We just invest in what our patients need. And as a consequence, we've been able to cut the hospital admission rate by about 40%. We're one of the 5-star practices in that quality program that we talked about before. And the future for us is continuing to grow, to add more plans, and really as CMS continues to invest in programs like MA, get into more communities and take care of more patients.
Chet?
Sure, great. Good afternoon. I told myself I wouldn't mention this, but like you, I began here on Capitol Hill after college. That was in 1987. I made $12,000 a year, and we used to handwrite all our boss' signatures. So when we had a mass mailing, I wrote 6,000 Bobs for Congressman Bob Matsui. It took 2 days, but it was high-level work. In any event, thanks for being here. So a quick word on AMGA. AMGA, we represent, as Congresswoman Schwartz said earlier, sort of the large health systems and group practices along the country. The names you'll recognize are the Mayo Clinic, the Cleveland Clinic, where I used to work, Intermountain, Geisinger, Kaiser. We're in 49 states, not Rhode Island for some reason. I think as I look at the membership, we're a little more on the tip of the spear as far as moving to value or taking risk is concerned compared to others. And in fact, we do a risk survey every year of our members, and we ask them, where are you on the risk spectrum? By that, what percentage of revenues are risk-based versus fee-for-service? And by and large, our members are moving to value in a fairly significant way. One of the biggest takeaways from our surveys is that Medicare Advantage is the most favored value product in the whole healthcare system. That's not just Medicare and Medicaid. That's the federal setting and the commercial setting. Our revenues have increased from 22% of total revenues in MA 4 years ago. Now, almost a third of our group's revenues are MA-based in the federal sector. And in fact, according to this year's survey, our members expect that Medicare Advantage revenues will surpass traditional Medicare revenues in 2020. That's sort of an amazing fact. If you asked a CBO what would happen 10 years ago, they never would have said that. So just let that sink in. Medicare Advantage revenues will surpass traditional Medicare revenues amongst our members in 2020. So our members move in MA in a really, sort of a very significant way. And we asked our members, why is this? Why are we moving away from fee-for-service into Medicare Advantage? And they gave us several reasons. One is, and I think, Griffin mentioned this, and Medicare Advantage's financing model aligns perfectly with the way our members deliver care. Our members deliver care in a team-based, coordinated fashion. It's highly EMR enabled. And the way this is financed, it helps them deliver the care. For instance, to do well in a risk product, to do well in Medicare Advantage, you need to have an infrastructure that allows you to do that. You need to have pharmacists that help you at the bedside with medication reconciliation. You need care managers that can take care of a complex set of chronically ill patients. In fee-for-service, none of those investments are paid for. And in fact, in fee-for-service, let's say one of our members, Cleveland Clinic, let's say they spend $1 million on hiring 10 care management nurses, take care of patients with COPD. So by taking care of these, by investing $1 million in COPD patients, we also reduce admissions on the Part A side, the hospital side, by another $1 million. We lose $1 million in investments, and we lose $1 million on the hospital side because we reduced admissions. So in fee-for-service, none of this care infrastructure is incentivized. A Medicare Advantage, it is. I think James hit on that also. And also, somehow Medicare Advantage has created an environment where there are partnerships between the providers and the payers, which is fairly rare. If any of you have parents who are doctors? Okay, so ask your parents, do you like dealing with the insurance company? They'll probably typically say no. So Medicare Advantage is actually different. There's the incentives have actually aligned where the plans and our members, at very least, can work to target and create and reward interventions that take care of high-cost, high-complex patients and also incentivize prevention of care. And the best place for a senior citizen to be is not in the hospital. It's to prevent that hospitalization from coming. So the way MA finances our models, that actually is incentivized. Also, MA will fund the infrastructure that we need to succeed under risk. As I mentioned, fee-for-service doesn't pay for the care managers or the EMR development, but Medicare Advantage can, and typically does. Also, when our members create value, again, by creating care management processes that take care of high-cost patients, Medicare Advantage actually helps us finance that value. It helps us capture that value as well. So as I look at it, MA helps our members on the reimbursement side by appropriately risk adjusting patients. It helps on the expense side by funding care management processes that are so critical to taking care of an elderly population, and also incentivizes to provide quality by aligning with the Medicare Stars system that James talked about. And critically, so as a beneficiary of Medicare Advantage, you actually enroll in MA. So our members know exactly who's in our Medicare Advantage population. And that allows them to target interventions that either, one, prevent you from going to the hospital, or two, take care of high-cost, complex patients. That's not the case in ACOs, for instance. Have you ever heard of ACOs? So in ACOs, you're essentially allowed to go see anyone you want. And our members don't know who's in the ACO population. And that makes it very difficult to control costs and improve care. But in Medicare Advantage, you know exactly who you're treating, and you can design programs around those people. And finally, and James also hit on this earlier, members are moving to MA because their patients are. 10,000 patients go to Medicare, join Medicare every day. I think James said 50% of those are actually joining Medicare Advantage. So as the beneficiaries go there, our members have to go there also. So a host of reasons why Medicare Advantage is so popular with our members. But that is where the members are going as a whole, and I think that's where Congress needs to incentivize value as we go forward. Thank you.
We're putting him on TV. I know. Go ahead, Jim.
Thanks for sticking around for this presentation. I really appreciate that. Congressman Schwartz asked, how is Medicare Advantage real? And so for Teachers Retirement System of Kentucky, it's been very real for the last 13 years. So we were an early adopter from a public sector standpoint, a very early adopter of Medicare Advantage. Many of you in this room were probably still in first grade when we adopted Medicare Advantage. I have the pleasure and the opportunity of representing 35,000 retired teachers that are on our Medicare eligible health plan. 6,700 of those are over the age of 80. 39 are over the age of 100. My oldest is 109. The second oldest is 108. 72% being teachers, so 72% are females. The cost trend, our premiums charged, are continued over this 13 years. We've been able to bend that premium cost and are still doing so. We use both, of course, a fully insured Medicare Advantage plan, and we currently have a self-funded Medicare Part D EGWIP, Employer Group Waiver Plan. Both of those two together are shaving $1.9 billion, that's with a B, $1.9 billion off our 26-year, what's known as OPEB, Other Post-Employment Benefit Actuarial Liability. So the savings from those is helping us 26 years from now, that's for sure. It's also helping us in the current year as we speak. In our 13th year, our medical premium, so 13 years ago, we were on just a simple Med-Sup plan, Medicare supplement plan. And so our premiums at this point in time are still about $89 lower in our 13th year than where we were at with a Med-Sup in 2006. Now, unfortunately, there's a couple of things going on, and James mentioned one of them for sure. There's a couple of things going on that could threaten this $89 savings that we're still looking at. One is the health industry tax. You know, of course, the uninsured and the underinsured, there needs to be revenue streams to pay for that. My argument would be maybe not Medicare, not on the backs of Medicare folks. So that means about $25 per person per month for all 35,000 retirees. So our premium is going to go up by that amount in 2020 if the HIT, the HIT, the health industry tax is not waived for 2020. So very important. I talked to all of the 8 congressional delegates for Kentucky yesterday. I'm really trying to make sure that hopefully this gets waived in 2020. In addition to that $25, I'm sure you've heard a lot of discussion about the HHS OIG proposed rule for the rebates being given to patients at the point of sale. For a Part D, Medicare Part D egg whip, we are very, very different than how you would look at any normal commercial plan. So Teachers Retirement System in 2018, we received $27 million in formulary rebates. We took that entire $27 million and we deposited that into our medical insurance fund. And we used it dollar for dollar to buy down the premium of our Medicare eligible health plan. So if, in fact, going into 2020, if we lose those rebates and they have to be given at the point of sale, then unfortunately this just becomes a cost shift. Instead of a cost containment, it becomes a cost shift. And so we will simply have to increase our premium by the exact same dollar amount. That number's pretty hefty for us. It's $64. So if you look at the $64 possibly being lost for the rebates at point of sale issue, if you look at the $25 possibly lost at the HIT, that actually totals the $89 I just mentioned that we have still saved on our premiums comparing the premium in 2019 to the premium in 2006. Our members, our retirees, I get all kinds of compliments about this Medicare Advantage plan. Mainly because in achieving this savings, we also were able to pretty much mirror the existing MedSup benefit that existed in 2006. Now, we have made some tweaks, especially on the Part D side, but for the most part, the medical benefit for the retired teachers has not changed since the late 90s. And that's meaningful for several reasons. The average retired teacher, their pension is $36,000 a year. Retired teachers in the state of Kentucky do not pay into Social Security. So this is their main source of income. So they need a valuable, viable health insurance benefit. And our retirees for the last 13 years have found Medicare Advantage to be stable, dependable, affordable. We're a little bit different, again, being a customized group egg whip. We have what's known as a national passive PPO, which is very popular for retirees who like to kind of leave the state after they've retired. And so what that means is if we have a retiree that visits an in-network Medicare Advantage provider, then our plan does receive those discounted benefits. However, they're not financially incentivized, nor are they penalized. They may go to any doctor or hospital in the United States that accepts Medicare and agrees to bill at this point United Healthcare. As you've heard mentioned before, just really big believers in care coordination, disease management, all of these things that don't exist with the Medicare supplement that's out there. And of course, our members just love the value-added benefits, the hearing aids, podiatry, gift cards, incentives, silver sneakers, especially silver sneakers. And so we have just offered the telehealth program with our Medicare population, and we're kind of watching very closely to see what happens with both transportation and meals in that regard. And I think I'll stop there just to see if there's any questions.
Well, thank you. All three of you were really wonderful in really sort of articulating, and let's give them a round of applause. Was terrific. I do want to see some hands go up. I'm happy to start it with a question. But really, I'd love to hear from you about what your questions might be for any of the panelists. Well, while you're thinking about it, I'll kick off one. There's been reference to chronic conditions, and I think one of the facts I didn't put out there, but it's been sort of referred to, is that more and more seniors, well, Medicare was set up, originally the fee-for-service traditional Medicare was really designed for expensive hospitalizations. That was the point. You could bankrupt your family, didn't have the dollars, and now, in fact, the reality is that most Americans, while you still need coverage for those hospitalizations when you need it, that really more and more seniors in particular are living with and managing chronic conditions. And numbers are that 3 in 4 Americans over 65 have multiple chronic conditions, and 77% have at least 2, and 14% have 6 or more. And it's this 14%, some people say it's even 5% of beneficiaries really have very serious multiple chronic conditions, many of them with also limitations of daily living that make it very hard to actually then do all the things that you're supposed to be doing to take care of these conditions. Could any of you speak to how Medicare Advantage really does enable the attention to this group of, well, actually almost every senior having chronic condition, but particularly those who are really high need, high cost in the fee-for-service system, and how Medicare Advantage handles that differently?
Sure, I can definitely speak for what it means to our patients. I think 2 things. Number one, what you need to manage those conditions isn't always a doctor's visit or a pill. Sometimes it is, but when you have a benefit structure that allows you to be more creative, and I think some of the stuff we talked about before, whether it's transportation or community services or home visits, those are things that traditional practices can't really offer because there's no incentive. They don't get reimbursed to do that, and MA allows you to do it. The second is really the actuarial value of an MA plan is that out-of-pocket cost. You'll hear it called the MOOP, the maximum out-of-pocket. And when that's limited at $3,400, like in many cases it costs more to declare bankruptcy. So you essentially like take a 1-year medical bankruptcy off the table with that. And that's why I think you see that skew towards lower income, more vulnerable populations. And so it essentially means like you're allowed to get sick and go to the hospital and not have to be bankrupt because of this program.
Think about care coordination. There's a couple components to it. One is IT, and you do need certain software that identifies these high-complex, high-cost patients. You need also analysts and care managers to, once they're identified, call them and get them into the practice. And obviously you need nurses and physicians to take care of them. And a fee-for-service program, which we've mentioned before, none of that stuff is reimbursed. And our members invest millions, not hundreds of millions of dollars into care management processes and IT upgrades every year. And in Medicare Advantage, that sort of stuff is actually incentivized. And in fact, it's also rewarded. So when you're working on a budget and you keep people out of the hospital, which is what those processes are designed to do, at the end of the year, you do well financially. So it's a much better incentive. And the economic incentives around MA are much better for, I think, our members, which are your constituents, but also, more importantly, the patients.
Anybody? Oh, good. Go ahead.
I appreciate everything you said in your remarks, particularly about how the rebates being reflected at the point of sale would actually just shift the cost to premiums. I'm wondering if you support any proposals that actually would lower the cost for patients and beneficiaries.
Well, for me, I think that the starting place is the original drug list price. So I've been talking to the congressional delegation for Kentucky and just talking to them about let's not play with the symptom of the problem, which is the rebates. Let's see if we can do something about the original drug prices. And so ultimately, that has kind of been what my letter to HHS said, is leave the rebates alone from an EGWP standpoint. Let's work hard in terms of getting generics to the market, biosimilars to the market, and allowing the market to take care of getting those prices and getting those drug prices down.
It's a good answer, but we're happy to talk further, too, about other solutions other than this one. It is a real cost shift. It is going, and CMS acknowledges that it will increase premiums for everyone in Part D. They consider it a fair trade-off for us, and actually BMA has also come out opposed to this rebate rule and say, come up with other solutions. There are all sorts of other ideas out there about how they can, again, incentivize, particularly biosimilars. Move to generics has been very successful, but really getting them to market faster is certainly important, and as well as other kind of FDA kind of things that you could do. But it really is the original list price that is a real concern, and it's not clear that this is going to actually do anything to reduce the list price, and in fact, not even clear how effective it will be in enabling these plans to actually negotiate better prices with the pharmaceutical companies. So it's also one shot, and it's not a comprehensive solution, and it really doesn't bring the manufacturers to the table the way it needs to. Yeah.
Hi, my name is Krishna. I'm from Congressman Hoyer's office. I am currently getting my master's in public health within health policy analysis and evaluation from the University of Maryland. And my question is regarding the expansion of supplemental benefits, looking ahead in 2020 and beyond. While we do focus on improving and putting forth preventative measures to, I think we talked about providing air purifiers for people that have asthma. I think it's also important to indicate the importance of health education and workshops within the communities and really working and monitoring local governments and the systems, the health systems that work towards that, because a lot of the problems do occur when people of the community don't actually know what Medicare Advantage is and how to take care of themselves.
Well, a couple good comments. I don't know if anyone wants to comment on that, but there's no question there's lots of other issues that should be worked on. But I think what's interesting about it's happening in Medicare Advantage, they are, it's not a panacea for everything at this point. We'd love to think it would be, but it is opening some doors there. I mean, the fact that you can talk about wanting to be a community hub is really very important. Recognizing hazards that can be in community, recognizing the deficits that are in a community, and of course, that really make it much more difficult to live healthy lives. So you're up against all of that when you're also trying to provide good care, folks, and all of that. So any comments?
I can speak to, we do a lot of educating in our community centers, and there's a person in that center whose job is to educate people on what their options are, because definitionally they're beneficiaries of these programs. The Kaiser Family Foundation back in 2014 did a whole bunch of work to understand why it is people make the choices they make when they're Medicare beneficiaries. Number one reason people don't choose MA in that study was that they didn't know about it. We've done some work over about 1,100 people who are patients of ours. Number one reason they leave MA at the end of the year is they didn't know they left, and we just have to help them re-sign up. So I agree with you on education, but I think that's a thing that actually does have to be done by the community, and we do it as a provider.
And I'll say at BMA, there's some good information on our website you'll be interested in, because we also have about 400,000 beneficiaries who we work with to be advocates for themselves around Medicare Advantage. And it's complicated, you just heard, but one of the things that we heard from them, and we have acted on this, is really to push CMS to provide better information, more timely information in the process of enrollment, so that people understand the basic choice between traditional and Medicare Advantage, and to be able to understand, yes, you're in a network of doctors. You can see every Medicare doctor necessarily, but the fact is that there were some real advantages. And I think it was pointed out that our own polling shows that many beneficiaries who are in fee-for-service didn't even know about the option of a managed care option. Our own finding is that 60% of people in fee-for-service they don't know. They didn't know about it. And our own findings is that they tend to sign up a year or two later. But being able to keep people in Medicare Advantage, to be able to have them know about Medicare Advantage, it is, in many cases, a more affordable option and has more benefits. So we want to make sure that people are making an active choice between traditional fee-for-service and managed care. So we're pushing them to do that. We may have some legislation coming up on that to actually make sure that CMS is fair in this and providing the information. So happy to be back in touch with your offices. Happy to have Congressman Hoyer's office be involved, would be great. Because it seems only right and fair that beneficiaries really understand this option. And it's complicated to make those choices at that moment, but to really have both Social Security Administration, which actually provides that initial enrollment information, and also CMS to make sure that their information is understandable in the right languages and actually at the right health literacy level. We talk about co-pays and deductibles and all of this and cost sharing, and what is that all? So we think that making these kind of this choice understandable and easy to implement is really important, and we work on that. There's another question, yeah.
Question about clinical outcomes and how well the star rating system reflects beneficiaries' experiences. So we've heard quite a bit about how rehospitalization rates in Medicare Advantage. What about the chronic conditions and reduction and, how many negative life expectancy or even quality of life to some extent? And I think you mentioned that earlier that the star rating system is at the contract level. Explain a bit how that actually represents the beneficiary's experience.
Actually, James may want to bump it, but I'll do my best. But well, first of all, they can find out about what the star ratings is. I mean, 5-star plan is not easy to achieve. You can be 4.8, you can be 4.6. It's so maybe Dr. Myers wants to speak to how that really matters. You can find that out in the Plan Finder online. It's not in the handbook, so it's not obvious to consumers all the time what is a high-star plan or what isn't, although many of the plans tout that. And it really is an extraordinary program that's actually really worked. In 8 years, we moved from about under 25% of beneficiaries being in 4- and 5-star plans to 75% being in 4- and 5-star plans. And that's probably two reasons. One, consumers do figure it out. And two, the plans and providers really work hard to achieve a high-star rating because it is both a good marketing tool, but it does allow you to have these extra resources to provide the kind of care that they need. So it's really worked. It's kind of incredible how successful, and there's nothing quite equivalent in traditional fee-for-service. So it is, but I also think because it's a managed system, it also means they're managing the providers. I mean, maybe Chet wants to speak to that, but I think, Griffin, if you want to, it really means that you pick providers that want to work within this kind of system. And it really does create a network of doctors who are there for patients. And I think people start to figure out that that's pretty good. It's really quite helpful to them. Many of our beneficiaries talk to us about how having a care manager or a care coordinator or being able to see that primary care doctor 4 or 5 or 6, what'd you say, 9 times a year is extraordinary. It builds a trust relationship that helps improve health status. 2 reports I'd refer you to. One is on our website, which Avalier Health did do a report that showed improved outcomes, including fewer complications for diabetics. So it's harder to measure some of that, but we did find that. And you do measure some of this by people are not going to the hospital and their health status is just as good, then something's working. They're getting care in another way. And that's what we found was happening. And it helps doctors be able to work together as a team. And I think Chet spoke about this. So, Dr. Myers?
Yeah, I can make a quick comment. 3 things. I think the STARS metrics, I think if we think about them as a finished product, we kind of miss the mark because they change them over time and update them. And almost all of them, I haven't checked this year, but virtually all of them historically have been like from the AHRQ. So they're developed by experts in quality improvement, and they're really pushed down that way. So it's the same thing you would care about if you're an academic, whether or not you run a health plan. The second thing is plans care a ton about this. Virtually all of them, when we contract, will push that stuff down. So like if you don't, and I actually think it's rather easy for us because we've built all the infrastructure, but docs they get bonuses if they do well, and they miss it if they don't because they really push that down to the clinician level. And the third thing I would say is the Avalier report is a really good one. There's one from the Boston Consulting Group a few years ago that really took some of that health plan data to demonstrate that. I personally am less compelled by certain sources of data. There, however, is high-quality peer-reviewed literature looking at this. A study that I quite like with the largest numbers is from the American Journal of Managed Care in 2015 that really compared quality and cost. And you do see that for acuity match population, there's a meaningful improvement for MA.
Oh, the other study I wanted to mention is one that Humana did, and they were using, I believe it was, the CDC has a healthy days measurement, how many people, and so it's self-reported from mental illness to other kinds of health status kind of things. And they found a huge change for people living more healthy days in a year in their managed care plans. And so it is really having an effect both on the health outcomes, but also quality of life. And they're reporting, and beneficiaries are reporting that.
Yeah, I think from AMJ's perspective, and I'm not a STARS expert at all, but I do believe there's a patient experience domain as well as clinical outcomes domain. And I think what our members have told us is the star ratings measurement system is a good set that does actually improve quality and look at patient experience, and they contrast that with what's happening in fee-for-service, where they are frankly inundated with measures. One of our members said that they report 800 measures a year to various payers. So, which leads to, I'm sure you've heard about provider burnout, physician burnout, especially on EMR use. So I think they look at the star ratings as a reasonable set of measures that actually does what it's supposed to do, which is improve care.
Some of them are, I think, well, over a third for sure, are consumer experience. And it's done through surveys. People fill out surveys, it goes to CMS, and they report them on everything from did the receptionist answer, could you make an appointment, to how were you treated when you were there. So that consumer experience is very important to plans, as well as they don't want people to disenroll. They want, and you can. When you enroll in Medicare Advantage, you can change your mind every year. So if it's not working, you can go back to fee-for-service. Yeah.
A couple of you have mentioned that sometimes people don't understand that they're leaving Medicare Advantage. Can you speak about that confusion and some of the pain points for the enrollees?
Yeah, I can speak to that. I mean, so when we started our organization in Cook County, Illinois, which is where Chicago is, 8% of beneficiaries chose MA. Now it's about 30. It's really because the burden is up to you as a provider or a plan, not really a provider, but as a plan to educate beneficiaries on the topic. It's hard to do that. The Medicare and You book is like the book you get in the mail when you turn 65. I believe this year it's 118 pages. And this is what we at Oak Street sort of call the German beer problem, which is this idea of like if you're in a bar in Germany and you order a beer, it's going to come hot by default. It's not like if you want a cool beer, they'll give you one. It's the default. Like if you don't do anything, you're going to end up getting a traditional Medicare card. So you just have to educate people and do that in a culturally competent fashion. I think the comment on language was an important one. The overwhelming majority of our members are English or Spanish speaking, but we have care teams that practice in Cantonese, in Russian, and in Polish, and there are no MA product. There's no educational materials available for them. So we really take that burden on just to present options to folks, but it's hard. And I think that essentially comes as a line item for marketing for a lot of plans, and so it's a thing that they spend a lot of time and a lot of money working on.
A little different from our perspective. I have a full-time staff member that works on nothing but getting folks off another Medicare Advantage plan and getting back onto ours. So they're not understanding that we have a Medicare Advantage plan, even though I personally think we did a real good job of communicating that. But they're not understanding that they're on a Medicare Advantage plan, so they sign up through a spouse's plan. They sign up through someone coming to the door and trying to sell them an individual Medicare Advantage plan. When they do that, the Medicare rules basically say whichever enrollment is the latest, that's who you're with, and so it automatically terminates their Part C and D plan through Teachers Retirement System of Kentucky. And so I have a full-time employee that does nothing but look at daily reports that report who has accidentally been terminated off Express Scripts or United Healthcare in this case. And then from there it becomes a huge concierge process, again, with an average age of 74 and 6,700 over the age of 80. They have no idea how they've ended up in this situation, but if we don't get them re-enroll quickly, then they've lost the benefit of our plan. So it's quite a busy thing to keep up with and keep that communicated and make sure that our retirees don't, some of them are under that impression, and it's kind of a culture from a while ago. The more insurance you have, the better. If you remember that. And so I think, in my opinion, Medicare tried to fix that. And one way they did that was say you can't have two Medicare Advantage plans. You can't have two Medicare Part D plans. But in doing so, again, that's kind of a trap sometimes for our retirees. But a good job security for my person that does that on a day in and day out basis. Yeah.
Thank you so much. I found this very informative. My question pertains to the supplemental benefits as well. I think one of the kind of areas that I found to be not necessarily covered in that list, but seems to be such a huge indicator when it comes to health outcomes. And our district is in the Boston area, and like many urban areas, we're
So I'm just curious about the role that you see Medicare Advantage plans kind of playing in kind of mitigating some of the impacts of the affordable housing crisis, but also in the sense of like encouraging seniors to be able to age in community and kind of how that benefits them in the long term when it comes to their health outcomes as well.
Yeah. Actually, Dr. Myers, you have to leave soon, by the way.
Oh,
also,
no,
but I've got a little note that you're supposed to leave soon, but anyway, they have a plane to catch. But do you want to
I'm
comment?
happy to give, like,
to do
I used to live in Boston. I know exactly what you're talking about. We face it everywhere. We do a lot of work with the Chicago Housing Authority. It's super hard. And I think it's just I would like, it's a very hard problem. It clearly has impacts on health outcomes. I think it's one of the top 2 or 3 social determinants. I just think stepping back, if the HHS budget were intended to include like rent for everybody who's a beneficiary, we would think about it very differently. I will just say, I am told that United Healthcare and Kaiser are working on like providing housing for their highest risk beneficiaries. And I think it flows through from that risk-based mechanism that MA has. So if you're ever going to see it, I think we'll see it in this model. But I'm tempering expectations for our own teams who are asking me about this.
And I could think there is some interest in trying to do this, but again, how much they can do and whom. But certainly some of the, trying to ameliorate some of the issues that people have in their, and substandard housing is certainly an issue. So that whether, again, it's some home modifications that could help, that might be widening a door, letting you be able to stay in your home if you can, or doing a stair glider kind of thing could happen. The other is some of the in-home care helps people stay in their homes if they can, rather than going to either other housing or they can stay in their community. But they think there's a strong interest, certainly from beneficiaries, of people wanting to stay in their homes. Sometimes it's not tenable, wanting to stay in their communities at least, and to be able to have some affordable housing options for them in their home communities is something of interest. I'm not sure Medicare is going to be able to solve all these problems, but the fact there is really, United has somebody working on it to see if it makes some sense. And so are interestingly, some of the long-term care organizations, and some are also thinking about how can they also provide more affordable housing and support in home and in communities to enable people to stay in their communities. So it's a conversation, but it's really a huge, huge issue that needs attention. But we're paying attention to the degree we can, and obviously think that there are also some other players here who could be helpful on this.
Yeah, I think it's at its very beginnings. When you think of a healthcare system like Mayo Cleveland, usually once they finished treating the patient, that was where their job ended. I think, and that was certainly the case when I was there, 6, 7 years ago. But I think now the members are looking at things like affordable housing, or developing housing as a really important part of addressing the whole patient. That said, it is just starting, and there are some very nascent programs that actually do that, but the end is low. It's like 20 people. But I think physicians, and particularly sort of the health system leaders, are looking at themselves and saying, we're not just a healthcare system, we have to be involved the whole community, and that includes behavioral health, it includes affordable housing, all that sort of stuff. And actually our members do have sort of the capital to be able to do that sort of thing. Atrius might be in your district. I'm happy that Atrius is a big system, and they may be doing some pretty innovative stuff. They've been doing capitated work for 20 years, and I'm happy to hook you up with some folks over there.
It's also where there's some of these community partners are really, the area agencies on aging are really also looking at how they can expand what they're doing, not only in services as well, and how they might be able to do that in conjunction with Medicare Advantage plans, which is kind of an interesting option as well. So I think we can stick around, our staff can stick around a little bit, but look, we're right on time. Thank you for staying, and thanks so many people for coming in. Let's thank our panel for taking their time to be here.
Yeah, I'll tell you what, here's, I knew you got a split.
Oh, here, I can give
I'll tell Bowen I saw you.
Oh, yeah, I was just going to text him on the way out. That'd be awesome.
Yeah.
Thanks so much.
You all did really fantastic.
Oh, thanks for having me.
Oh, yeah, exactly. Thank you. And thank you for the summit.
Oh, yeah.
I really appreciate this. It was great for you to take your time. And I'm going to send a...
Oh, you did?